Good afternoon, ladies and gentlemen. I'm happy to be here to present my 18 months progress. The theme of my PhD program is new insights into viral infection-related acute pancreatitis. My name is Gefu, and I'm a PhD student and a biologist from CTM. My vision is to improve the prognosis of acute pancreatitis patients by investigating less common etiologies, and my mission is to explore the effects of viral infection in GI system. Now, I have two specific goals to achieve my mission. The first one is about concomitant viral infection and acute pancreatitis, and the second one is about the role and the prevalence of acute pancreatitis in COVID-19. Let's start with the first one. Concomitant viral infection is a risk factor for complications and a worse outcome in acute pancreatitis. It would be a systematic review and meta-analysis. The incidence of acute pancreatitis has been increasing for past 10 years, and viral infection is a direct etiology of AP, even though the most common etiologies are biliary-induced and alcoholic abusing. Viral infection could be a potential trigger for AP, and many kinds of virals are reported and related to acute pancreatitis, such as mumps, Coxsackie B virus, hepatitis virus. In recent years, COVID-19 is reported has a correlation with AP, so we would like to investigate the effects of concomitant viral infection in AP. Our clinical question would be, what are the effects of viral infection on the clinical outcome in AP? We include the patient hospitalized with AP, and the exposure would be concomitant viral infection, and we collected mortality, severity, and complications of AP as outcome. We assume that concomitant viral infections such as HBV are associated with a worse clinical outcome in AP. And as for complication, AP patients with concomitant virus need more cautious pancreatitis management strategies to get a better prognosis. We conducted a systematic search based on 3 English databases, and we also checked Chinese databases to see a higher prevalence of hepatitis virus in China. At the end of the selection, we finally got 28 cohort study and more than 800 cases. When we do the analysis on cohort study, we found enough eligible cohort studies to make a subgroup for SARS-CoV-2 and HIV infection. And for the other virus, we also collected case reports and case series to support our systematic review. For table 2 is about prevalence of different outcomes. For example, the in-hospital mortality is around 19% in SARS-CoV-2 infections population, and in the control group, it's about 4%. Now, I would like to introduce our most important results. When we do the cohort studies analysis, we could see the odds ratio of 3.15, which means in-hospital mortality is more than 3 times higher in SARS-CoV-2 infected group. The confidence interval and I-square shows our results is significant and has low heterogeneity. Also, we investigate the severity of AP. The risk of at least moderate AP, which means moderate plus severe AP patients, is 2.7 times higher in infected group. This result is also significant but has high heterogeneity. We investigate necrosis as complication. The risk of necrosis is 1.87 times higher 1.8 times higher in infected group. That might be the reason why in-hospital mortality is higher and the patient has a more severe disease. Now, let's focus on HIV subgroup. In this figure, we could see there is no significant difference between AP-HIV population and regular AP patients in hospital mortality. And we also investigate complications such as sepsis and overall organ failure, and we get the similar results. According to our results, we can conclude that SARS-CoV-2 infection make a higher risk for in-hospital mortality, necrosis, and a more severe outcome in AP. Patients really need closer monitoring for local and systemic complications. And for HIV subgroups, patients are not expected to have a higher risk for a worse overall outcome. Our results is important because they show that we should consider viral infection in the assessment and management of AP. AP virus patients have increased susceptibility to serious pancreatic complications, and the patients need closer monitoring and timely intervention to prevent the local and systemic complications. What's the value here in our results for research? The possible viral infection should be investigated more, and the registration of complication and outcome should be more accurate. Our meta-analysis is the first comprehensive investigation on virus infection and AP, and our sample size is large, and lots of complications are investigated. But we still have some limitations. Our study types are cohort study and case series, case reports, and the reports of outcome is not complete. Most of the virus types do not have enough eligible cohorts. The analysis of the case reports is still in progress, so that's my manuscript state, and it's around 80%. We plan to submit it in March. Now let's continue with the second project, investigating the prevalence and the role of acute pancreatitis in COVID. It would be a registry analysis. COVID-19 is a worldwide pandemic, and the periodical emergency of human coronavirus, which happens in 2003 and 2019, suggests that we might face a similar situation in the future. And COVID-19 presents GI symptoms in up to half of the patients. The virus, the COVID-19 infection, we could see in the picture, the COVID-19 infection and pancreatitis-inducing factors could induce a cytokine storm by lipotoxicity, and finally results in a severe disease both in lung and pancreas. So, but now the prevalence and the role of AP still remain a question, so we would like to investigate it. The clinical question would be, does the presence of AP change the prognosis and management of COVID-19 patients? And we included hospitalized COVID-19 patients. The exposure is presence of AP, and mortality, severity, and the complications of AP are collected as outcome. And we assume that presence of AP make a worse prognosis of COVID-19 patients. As for the implication, acute pancreatitis in COVID-19 patients requires a specific screen to preventing more severe systemic complications. Well, we are planning to use coronavirus registry. More than 1,700 cases from 5 centers are included, and we would like to use we would like to use the information of development, epidemiology, diagnosis, symptomatology, therapy, and genetic background to support our analysis. So let me summarize my progress. The first article is planned to submit it in March, and the second one in August. I would like to end the presentation by the quote from Albert Einstein: "In student life, the most important driving force of work is the pleasure in work, the pleasure of working as a result, and the recognition of the social value of these results." Thank you for your attention.
Let me ask the first question. Why do you think that, for example, HBV infection would worsen the outcome of acute pancreatitis? It is a chronic viral infection similarly to HIV, and you pointed out that HIV is not associated with worse outcome. Why would you think that HBV, which is also a chronic infection, is?
Yes, for now, the results about HBV is still on progress, but there are so many, not many, but there are some case reports shows that HBV infection patients get a worse outcome in AP patients. But for HIV, I think that would in our study, most of the patients concomitant infected by HIV are well treated. Part of them are from USA and part of them are from South Africa. I think in USA, 90% of the patients are well treated, and in the study from South Africa, 70% of patients are well treated. So maybe that's the reason why the in-hospital mortality is not that different. But I still doubt that the sepsis and overall organ failure, that kind of complications are not different, because our sample size is not large enough. Maybe in the future we could collect more data for the complications.
I have a question. You mentioned that you're analyzing some case reports right now. So what are you doing with the case reports?
Well, we are checking the follow-up time and the the time of patient who died, and we try to make a survival rate like this.
Are you at all concerned about selection bias in those case reports? Because it's obviously the most interesting cases that are being published.
Yes, it's a little bit hard, but we enlarge the range of the selection, and we would like to try to include almost all patients who have a concomitant virus infection and AP. Some cases are after surgery, and it's very likely to get infection and secondary to acute pancreatitis. So that's okay. Interesting cases.
I would just like to highlight to you, so when you're writing your discussion and you're writing your limitations, try to highlight that is a drawback with case reports. So if you're including case reports, that's always an issue.
Do you recommend to screen any viruses in a patient with acute pancreatitis? And if you screen, which one? And if there is any positivity, what is the therapeutic consequence?
Yeah, definitely COVID-19 is the first option, and maybe CMV and some other, for example, HSV and hepatitis virus. I think they should be considered at this situation.